Hello, Jeremy Fernandez here with our weekly live stream to answer your questions about the COVID-19 pandemic and how we're progressing. This week we've seen a surprising increase in the amount of new coronavirus cases across the country, and that's prompted concern by some that restrictions are being lifted too quickly and that we run the risk of hastening a second wave. But what do the health experts say? Well, we've brought in our very own Dr. Norman Swan to take us through these latest developments. Now, feel free to leave your questions in the comments section below and we'll get to as many of those questions as possible. Dr. Swan, thank you for joining us again.
Hi, Jeremy.
Good
Norman
to see you.
The name.
Now, a lot of people have been talking about the pace of these restrictions being lifted in the past month or so. All around the country in various jurisdictions, we're seeing restrictions lifted, sometimes week to week. And at the very same time, these little clusters still popping up, particularly in Victoria. Are you concerned about the pace of the restrictions being lifted?
Not really. I was concerned, as you know, because we spoke at the beginning of the pandemic about the pace with which they were being imposed, and one felt that they were too slow at that point and they should have just come down. And there always were going to be contradictions and confusing things happening here. But the key thing to remember is that largely the states and jurisdictions have spent the time of the lockdown getting their testing regimen in place so that there's a good infrastructure for testing so that people with symptoms can come forward and there's no shortage of testing and no gaps. Still not sure it's absolutely right in the country, but we might get to, in rural areas, but there's not been much virus in rural areas. And people were going nuts. I mean, people were just going spare, being at home and isolated and so on. And there was only a limit to the extent to which you could keep going on the lockdown. And of course, there's economic. So I think we got to the point where, and we predicted it actually, that round about the beginning of June, end of July, was a time when we'd be down to almost zero community spread. And in fact, that's what we are down to. Most small states are down to having virtually no virus. Now, we should just define our terms here because people get confused. Because the Prime Minister talks about suppression, which is not wrong, but you hear the word suppression being used, you hear the word eradication, and you hear the word elimination being used. So let's just work out what we're talking about here. So, and they think that New Zealand has eradicated the virus. So New Zealand hasn't eradicated the virus because they're getting people coming in still. New Zealanders are coming home with the virus, being quarantined. So there's virus in the country. The key thing is that what they've done is eliminated, by and large, eliminated community spread. So that's the thing we need to focus on. It's similar to suppression, but that's really the focus is not so much have we got 21 cases and there's 18 from overseas. That's not something to be anxious about. It's how many are community spread, and that's it. So Victoria still has community spread, very small numbers. It's arguable whether there's community spread in New South Wales, but there may still be at a very small level. But what could be happening, for example, is, and which confuses people, is there's two or three things that create a confusing situation here. One is the test is not a brilliant test. Through no fault, it's not because it's a bad test, it's just the way it is.
In that it's not perfect, is that what you mean?
It's far from perfect. So it's called the false negative rate. So you could have the virus and the test fails to pick it up. And it depends where you are in the infectious cycle of the virus, whether or not it's positive or not. So if I test you and you were infected yesterday, it's almost 100% chance that the test will be negative, even though you're infected. And then that chance goes right down to about day 8 after infection, where there's still a 20% chance that if you're infected, you still come up negative on the test. And then the false negative rate goes up again. In other words, it becomes less accurate as it goes up beyond that. So first of all, the test is not super accurate. But it's the best we've got, and with this test, we've managed to control the pandemic. So it's not.
So it's working to a degree.
To a degree. Yeah. But then the other thing is the incubation period. So on average, if you're going to get symptoms, you get them 5 days or so after you've been infected, and that 14 days, which is the time people are sent in quarantine, will catch maybe 95% of people. But that still leaves 5% of people who may still develop the infection after they've been in quarantine. That's the second thing. The third thing is that you could have been in quarantine, positive, and then you've had a couple of tests that are negative, you go home and they've been false negatives and you've still got the virus. Fourth thing is you could have gone to the Black Lives Matter demonstration. You're in your 20s, you've caught the virus, or you've had it and you spread it to others, but you don't mix with older people, you only mix with the other 20-odd-year-olds, and the virus is circulating in your group, and you don't know it because you're asymptomatic.
And everyone else in that age group is asymptomatic.
Asymptomatic, well. And you get a spread in a group of people, maybe in a flat. There's 3 or 4 of you in an apartment. You get a little cluster, and then suddenly it breaks out. And if the incubation period's a bit longer, suddenly 3 weeks later it pops out or 4 weeks later after the demonstration. I'm just picking the demonstration as an example.
Well, a lot of people have been talking about it because those demonstrations took place just under 2 weeks ago.
Yes.
And some people are sort of waiting to see whether that will precipitate what's being called a second wave. What's your feeling about when we'll get a measure on that?
Well, I think we should have had already, because the bulk of people will have come out, will have developed symptoms or what have you. But if they're younger people, they may be asymptomatic. And most of the spread comes from asymptomatic people. Either they're totally asymptomatic through their infection, or they're pre-symptomatic and they're spreading it before they develop symptoms. But I still think most of it would have come out. Look, in those demonstrations, people were being responsible. They were wearing masks, and they say that you need about 60% of people wearing masks, or proper masks, or triple-layer cloth masks or surgical masks, for it to be effective. And eyeballing it, it looked as if more than 60% were. So 2 factors: not much virus in the community. People were wearing masks. I suspect the risk from Black Lives Matter was very low. But if you're going to see it, it still could be a little while. For example, the Diamond Princess, it was likely that it took a while for some Diamond Princess cases to emerge.
This was the ship in Japan.
That was the ship
right
in
at the
Japan.
start of the pandemic.
Yeah, and then we had the Ruby Princess, and we've had some odd cases popping up quite late in the day. So funny things happen, and then people can stay infected for up to 6 weeks, not necessarily...
And without knowing it.
Without necessarily knowing it, that's right.
OK, so we've seen, as these restrictions getting lifted, the number of cases and clusters in Victoria also on the rise. Is there something particular about the Victorian situation that makes it more exposed here? Why are we seeing these clusters appear in Victoria and not, say, in WA or the Northern Territory?
Well, we all know that Victorians are more friendly than other Australians. There's some truth to that.
They've got to keep warm.
They're more social. Well, not a silly idea that people might be indoors. I think Victoria's just unlucky. I think there's just more virus there. In theory, it should be New South Wales, because more people have come in from overseas into New South Wales than Victoria, but a lot have come into Victoria. I think they're just unlucky. They're doing a lot of tests. And I think, the meatworks was a big outbreak, and they've just had a couple of clusters. And this is a virus that needs a cluster to take off. And I think there's misfortune is in here as well. I don't think they're doing anything different or not doing anything other states are. So Victoria is struggling a bit, but it's still not a lot of virus. It might look like, 2 days ago, 21 cases. But I think within that, there was 4 communities spread. So it's not as if we're in double digits for community spread. We're in single digits for community spread.
It's not a lot in one view, but on the other hand, the impact that it causes in terms of lockdowns and shutdowns and social distancing and border closures is quite impactful.
Yeah. So what we've got to do now is get to a different kind of control. And that control is, and it's kind of happening in Beijing at the moment, where you've got that big wholesale food market, an outbreak from there. You can't totally rely on what the Chinese, unfortunately, what the Chinese are saying because of what happened in Wuhan in January. And they're worried about it, and they're so worried about it that makes me wonder whether or not it's bigger than it actually is. But the traditional way, when you've got not very much virus in the community, of doing this sort of textbook public health is you find a case or an outbreak and you put a ring around it of 5 or 10 kilometres radius, and then you lock down or test intensively within that area, but you don't shut down a whole city or a whole state, and that you go after those contacts. And that's what the Victorians, by and large, are doing with those contacts. The Victorians are also doing what other states are not doing, which is they're doing genetic tracing. So they can do the genetic profile of the viruses, and they can often trace where the virus came from the genetic profile of the virus. So they're better equipped in Victoria. So it's just a bit of a mystery why they're struggling.
Something, just to pick up on that point, someone wrote to us asking why not lock down local government areas instead of the whole state, pointing out that most of these outbreaks and clusters are taking place in the larger cities, and that's dragging down the economies and the communities in regional areas as well. Why do regional areas need to come along for this ride of restrictions and isolation?
Because at the beginning, we're in a different situation now where we're coming out of it, and there's not that much difference now between the states in terms of coming out of lockdown. We're roughly the same. Victoria has been a bit stricter, and you can start to understand why they've been a bit stricter than other states. If you have one rule for the country and one rule for the city, there's mingling between the two. Yes, you could set up barriers and not allow people into Bendigo or Ballarat or what have you, but that's really hard to do. But if it got into rural communities, it could spread quite quickly, particularly in disadvantaged groups. So rural communities might feel bulletproof here, but because you've got the potential for bigger clusters, particularly if you've got a meatworks in town and that sort of thing. And to say in the patchwork of rural Australia, this country town's okay because it doesn't have a meatworks, but this one isn't, is just too hard. You've just got to lock down everything, keep it under control. Border control is controversial, but it seems to have worked for the smaller states. And now we're in a situation where lockdown's coming up for everybody. But I think country towns felt bulletproof, but if they got it, they wouldn't be at all. Because I don't think the testing was there as quickly in the country areas as it was in the city. And in Aboriginal communities, it could be a disaster.
We've been getting a number of questions from people about schools as well, because obviously in the last few weeks, schools have started going back and more students going back full time. And we've seen outbreaks in schools where, in New South Wales and Victoria particularly, schools have been shut down, students told to go home, the whole school gets a deep clean. So someone asked us, why are children still being sent to school, this is in Victoria, when they've had contact with people who are linked to infection clusters? And I think this comes back to your point about not necessarily knowing when someone's sick until you get the result retrospectively.
Particularly in children. So children don't often get symptoms, and therefore you don't know that it's circulating there. It's not an easy question to answer, and people are anxious about it, particularly if they've got elderly grandparents and and this sort of thing. Let me just double back to the whole school story. So when I was talking early on that schools had to shut down, as others were too. The Commonwealth never wanted schools to shut down. The states were much more pro schools shutting down, but there were a couple of reasons why schools shut down. One was, to stop spread. So the reason that they say schools don't need to shut down is that you don't get that much spread amongst children. Well, it's not that you don't get that much. You do get some, but not a lot. It's true, and children don't get very sick with this. But it's not true that they don't get sick at all, because some do, and some children do die. But it's unusual and rare. But the main reason that you shut schools is that you can't go to lockdown with schools open. If you are wanting to get full social isolation and get control of a pandemic, schools have got to shut, because as soon as schools are open, you've got a lot of people circulating twice a day, picking up kids, taking them home, public transport. The infrastructure around schools requires a lot of social mingling. And so to get full socialization, you've got to shut schools down. So opening them up when there's not much virus around is relatively low risk, as long as we're doing a lot of testing. And yes, the price you pay for that is that the odd kid will pop up now and again, child or student will pop up again with the virus. And yes, you've got to close a school for a few days to do that. But that's less disruptive than every school in Victoria or every school in Western Australia being shut for a prolonged period of time and everybody being on homeschooling. The price we pay for opening up is that, yes, we will see clusters, we will see outbreaks, and it will test the testing regime. And the testing regime will be very expensive, because we'll do tens of thousands of tests for almost no positives. I mean, a general practitioner wrote to me today saying, look, I'm doing hundreds of tests on my patients, not one's positive. Well, that's actually good, and it's good that he's doing testing. But that's the price we pay, is that it will be brought out. But the risk is really low.
Another question on border closures. How safe would it be to travel by plane, train or even car in enclosed cabins once the borders do open? even within states. I mean, WA's in the last few weeks allowed people to travel from the far north to the far south, and interstate borders are being opened as well. How safe is it to jump on a plane or a train to get around?
Well, I think until we've eliminated spread, then my view is that you should, in public transport where you can't socially distance, you should be wearing a mask. And I'm not quite sure why we're not doing that, because that would make it much safer. Because it's quite unusual, although we're talking about cleaning surfaces, before we did this program, people were coming in and cleaning the surface here, making sure that you and I are not going to get affected by surfaces. It's actually quite rare to get it off a surface. It's possible, but you catch it from droplets. So you and I are talking, we've got a safe social distance, but if we were here for an hour and a half during this program, this social distancing you and I have got would matter less, because you and I are talking fairly animatedly, and we could be exchanging virus even at a distance. So I think on a plane, people should be wearing masks. It's a very low chance, and that would reduce the risks quite dramatically.
So when an airline or a train travel company or a public transport operator says, don't worry, we're cleaning the cabins, how much reassurance does that give you?
Probably 10%.
Right.
90% is breathing somebody else's air. If everybody was really silent and had a vow of silence on the plane, the chances would be even lower, but that's not possible. Whereas if you actually wore a mask, you would add on another 70% to that, according to the current evidence. So it's quite a big reduction, and would allow. So cars, driving up in a car with your family is very low risk, and it's very low risk that you might get the odd case popping up for somebody having a holiday in Port Douglas from coming up from Melbourne. But there are so few Victorians with COVID-19 virus, the chances are really low. And it's just up to the Queenslanders to have a testing regime in place. So what do they want? Do you want to open up your tourism industry, get jobs for Queenslander, and allow Southerners to, Mexicans to spend money in northern Queensland and revive the economy for the price that maybe, just maybe, you get the odd case? Now, this is not a silly or neurotic line of questioning, because back in November, there was only one person in the world with this virus. And now, as we talk today, 8 or 9 million people have been infected, with hundreds of thousands of deaths underestimated. So it doesn't take much for it to spread, but it spreads in an environment where people are not coming forward for testing, and you don't have the testing in place. Now we've got it. In the early days of this, when you and I first talked about this, it was quite hard to get a test. Now it's not.
And face masks as well at the time. I mean, someone wrote into us asking, why is it that the health advice hasn't shifted in line with what the WHO is recommending now to use face masks in public places? So
the WHO recommendations on face masks were tailored to how much coronavirus was in your community. So it varies a lot. So if there's a lot of coronavirus, then you should be wearing masks outside. By the way, the risk of catching this outside is much lower than people thought at the beginning of the pandemic. So it's low risk unless you're crammed together for extended periods of time. So it's low risk outside. It's indoors that you catch this by and large, and in clusters. Office space, gymnasia, choir practice. You're expelling a lot of air. So the WHO advice was tailored to that. But they did say, if you're going into an environment like an office space where social distancing can't be done and it's going to be extended anyway, you should wear a mask. If you're going to public transport where you can't socially distance properly, you should wear a mask. And I'm not quite sure why. So in the early days, it was because you would have had a run on surgical masks. There wasn't enough protective equipment in hospitals. Dentists were talking about a very high risk group, were saying they didn't have enough masks to look after their patients. And then we were going to say to the community, wear masks out in public, when even then it was fairly low risk. You just couldn't do that. But we're in a different situation now where we've proven that a triple layer cloth mask does work, is effective, that homemade or bought, and a surgical mask is quite effective too, and the hospitals and doctors are pretty well covered now. What's not that, and it's to protect other people, not to yourself. What we know, by the way, is that the N95 mask, the fancy one that was in the bushfires, very good for particulates and cleaning the air that you're breathing in, and industrial situations, but it's got to be a good seal around. And the one with the valve at the front is not one that you should be wearing in COVID-19, because the valve is only one way, so it filters on the way in, but not on the way out. So when you breathe out, it goes whoosh through those little holes, and if you've got the virus, you're spreading it probably even more than you would otherwise. So it's got to be an N95 without that one-way valve.
A number of people have asked, how much longer do you see us needing to practice social distancing and increased hygiene? Are we looking here for a vaccine or elimination or suppression? Or what's the benchmark here and what's realistic?
I think that if we get to a point where there's no community spread in Australia for, say, a month, so 2 cycles of the virus, we probably could safely stop that. The problem is, when do you open the external borders? Because as soon as you do, you create risk. And then you're going to have to tell people you're going to have to socially distance yourself again.
And from that point of view, the borders have never really closed to Australian residents. I mean, you see planes coming in all the time. People are arriving, Australians are arriving home, and there's a fair whack of them who are carrying the virus.
Yeah, so what is it, 80,000 people or something? Yeah. 60 or 80,000 people have come in. That's true. But you and I are not allowed to fly out and go to Bali for a week and come back. So that's really what we're talking about, is, you know, a much more relaxed thing. So they're talking about business people to being able to come in on a green lane. Well, that's got high risk too. So I think that while, although we're an island and reasonably under control, I think we should just be prudent, and we should still maintain that we don't kiss strangers, and we don't know what you do about creating relationships in the time of COVID. But actually, we've been asked to do a black label CoronaCast just to actually talk this through.
I've got a question on those lines for you.
I'm happy to take it. I'm not sure I know the answer. But what was I going to say? I just think that prudence, social distancing, being careful. My behaviour is, I'm very careful in the supermarket. I'm careful in the office here. I'm washing my hands a lot. I'm not wearing a mask in the office here because there aren't that many people here. But I think, for example, the ABC, when it starts to open up, probably there should be a bit more mask wearing at work until we're sure that. But a vaccine is when we're really going to be able to relax.
Now, let's talk about relationship making in this coronavirus.
I can't escape the black label story. Children, go to bed.
Block your ears, yeah, that's right. So someone's written to us asking if, we can expect a big drop in STDs and other types of diseases. So we're not talking about just black label diseases here, but because they haven't had a chance to spread at the usual rate in the usual forms of contact. Now, you've got that on one hand, and anecdotally you hear from people that, the hookup apps are going bing, 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 bing all the time. There are a lot of people looking for company on those apps at the same time. Do you have any data yet about how that's all playing out?
I looked that up this week. Largely, they report on STD. Most states report STDs on an annual basis. So I don't, there's a little bit of indication. I think it was from Queensland. So we did look it up this week. We've got some questions on it, CoronaCast. Context. We were not doing well with STIs, sexually transmitted infections, in Australia. We've had in some states, quite large increases in gonorrhea and large increases in syphilis, and small increases, but still increases rather than decline in chlamydia. So we were on an upward trajectory. Now, so just a slight to the side. Influenza. We had an early influenza season, and influenza notifications dropped quite considerably in March. Maybe because people weren't coming forward for testing, but it looks as if they dropped. Total number of influenza cases is roughly the same on average for this year as it has been on the 5-year average, because we had an early season before COVID-19 came along. So we could have had we might have been heading for a really big influenza season. STIs, you'd kind of expect them to come down for a while. But whether or not the pent-up sexual tension is now being released with casual sex, then you could see a significant upsurge as lockdown goes up. So you would not be surprised if it had come down. And people say, well, how do you negotiate COVID-19 in this sexual relationships or even relationships of any kind? So the first thing to be said is, a prudent new relationship with somebody you're not you don't know, because you're going to have, there's a similarity between COVID-19, by the way, and sexually transmitted diseases. So I'm talking to you here, and the risk to me is everybody you've been in contact with in terms of...
That's right. I bring along my whole contact list.
As I do.
Yeah.
And so, but that's true in sexual transmissible diseases as well. So the modern thing is, if you're starting a new relationship with somebody, you should actually go to your GP and get an STI screen, so that you know at the start of your relationship, assuming that you're going to be faithful to each other, that you know what you come into the relationship with, and if you've got chlamydia, you get that treated. And you should be, if you're sexually active, you should be, because the highest risk sexually transmissible disease is chlamydia. It's only a urine test. You should be checked regularly for chlamydia if you're sexually active. That way, and you obviously protected sex. But what about kissing? Well, essentially, you need to check whether you've had symptoms of a cough or a cold or a fever in the last few days, or I have, and if you have, you don't, you socially distance, or you don't have a date that night, and you're just prudent along those lines. And because there isn't that much virus around, that risk is fairly low. People say, oh, well, is it sexually transmissible? Is it in your sperm and so on? Then well, first of all, if you're having protected sex, you eliminate that risk. It's likely that COVID-19 virus it's in most other body fluids, so it's likely it's there. But the chances that it's transmitted, for example, in blood transfusions, there's not been a case of blood transfusion transmitted COVID-19 as far as I'm aware. And but although COVID-19 virus has been detected in blood. So you just be prudent, and it's an extra layer of care. And you think about it before you've had 3 drinks on a Friday night.
Very, very good advice. Luann Carter's written in asking if there's been any broad testing of asymptomatic people nationwide yet. I mean, one of the issues you have is finding asymptomatic people.
Yeah, so this is an issue because you don't get reimbursed for asymptomatic testing, so symptomatic testing. Although I think if you turn up and you're worried at one of the public testing centres, you won't be turned away if you're asymptomatic. But what will happen is if you get a significant cluster and they start contact tracing, they probably will do much more mass asymptomatic testing when you're doing a suburb, an area around a cluster, so you'll get that. So, but as far as I'm aware, there hasn't been, they were talking about doing large population studies of asymptomatic, people who might be asymptomatic, but it's a needle in a haystack. The studies that are most reliable about asymptomatic spread come from the cruise ships. Quite good studies, not just Ruby or Diamond Princess, but Diamond Princess, and there's been another one. And that shows that a really significant percentage of people are infected and are able to spread the virus just as much as symptomatic people. And it's anywhere between 40 and 80% of people who are infected. So asymptomatic people are an issue. And coming back to this new relationship story, particularly if you're young, you're more likely to be asymptomatic the younger you are. You just don't know. So it means that the people around you, the slightest symptom, get tested. And that's probably the biggest insurance you have. And if you are worried, go to one of those testing stations, and I'm sure you won't be turned away.
We've had a number of people having a robust discussion on our platforms online about whether this outbreak that we're seeing in various clusters around the country constitutes a second wave. Is there a definition of what a second wave means and who calls it?
It's like one of the things, you know it when you see it. The second wave is when you've got pretty much uncontrolled community spread.
And that's not what we've got right now.
No, we've got community spread that's reasonably well under control, single digits each day. But if you started to see it's 4 one day, 8 tomorrow, 16, and you're doubling there, even at low levels, with that sort of starting to be looking as an exponential rise of low levels, that's when you're starting to work, and it's coming from all over the place. So it's not just Keeler Downs or another suburb of Melbourne or Sydney or what have you. It's spread and it's popping up all over the place, and you've got community spread, and it's not, your testing regime's not controlling it. That's when you're starting to see a second wave. And that's what they're worried about in Beijing, that they've got hundreds of potentially hundreds of cases. They may not be sure where they are in a very big city, and they're worried that they're going to see community spread, and that would be a second wave, no question.
What's the quality of contact tracing like in Australia right now?
Proof of the pudding's in the eating. It's pretty good. We've got this under control. You know, we're in, at the beginning of this pandemic, you and I were talking, it was Hong Kong, Taiwan, South Korea, Singapore. Singapore's fallen apart because of the migrant worker problem they've got in the dormitory areas. It's now New Zealand and Australia that are being talked about. We're there, and that's by Public Health 101 textbook. Not a single textbook on public health will have to be rewritten as a result. Not one will have to be rewritten as a result of this pandemic. This has been done by techniques that have been known almost for centuries. You find a case, you make sure that that's what you've got. In the old days, you couldn't test for it. You isolate, you quarantine contacts, you find as many contacts as you can, you quarantine them, and you ring fence there. They eliminated smallpox by that, but in smallpox you had the vaccine, and you vaccinated people in that ring fencing. That's the way you control it, and that's the way we've done it.
So one thing that hasn't been around for a long time is the COVID Safe app. Now, we were all being told to download the app. It's going to be very helpful in contact tracing. It turns out it hasn't actually been used in that many circumstances. Does that mean, someone's written to us to ask, has the app been a waste of money and time?
We've looked at that a few times now. I think the functionality was a real problem. There was too much secrecy around the app. They weren't as transparent as they could. They weren't willing to actually crowdsource improvements to it. So I think they could have made the app better sooner. There were a lot of quite selfless people who were willing to help out with the app. It wasn't as if it was something secret. However, I think the functionality has improved. I simply think there's not enough COVID-19 virus around for the COVID app to be tested properly. And not enough people have downloaded it. But I think that if we were to see a second wave, you'd see a surge of people downloading it again, and more people taking it, and then you probably would see some benefit. But where you would see the benefit is if you've got the signs of a second wave and you've got, one case here, one case there, and it's all over the place. That's when I think we'll be fairly thankful for the COVID-19 app. It's like a lot of things in this area. If nothing happens, you think it's been a waste of time, but nothing happens is actually the success story.
It's difficult to find proof that you've averted the disaster.
In America, they waited until there was a crisis, and by then, in Britain, too late. We didn't wait. And by not waiting, nothing's happened. Isn't that good?
Caroline Ashgrove on Facebook wants to know if you have any advice for people who are still in the vulnerable category, people who have comorbidities, other diseases, or are elderly. What advice do you have for them, given that the rate of spread right now in the community is so low?
Well, I think if you're living in Western Australia, South Australia, Tasmania, Queensland, the risk is really low. There's probably no virus around. And I think even when they lift the borders, there'll be almost no virus around. And I think if people are really worried, then, and they are very vulnerable and they're going out, they could wear an N95 mask but well fitted, and be taught how to fit it well by their GP. And then you're going to protect yourself in the environment and make sure your hand hygiene and so on. And if you've got grandkids, just make sure they've not got a cough or a cold, and the kids around them are pretty well, it's no problem. And then hug away. I mean, I don't think that the risk is that high. But if you're worried about it and the grandkids come, well, wear an N95 mask and make sure hand hygiene is covered. And I think it will reduce the risk from an already low risk to extremely low.
We had a couple of questions about asymptomatic carriers of COVID-19. Someone asks, if strong symptoms are a sign that your body's immune system is getting into action, so it's reacting strongly and vigorously, does that mean that asymptomatic people have a problem that their immune system is underactive?
It's a really good question. The studies suggest that asymptomatic people carry the virus for on average, the same length of time as people who are symptomatic. The predictor of carrying the virus longer is more to do with age. So if two people are asymptomatic, the older person of the two is more likely to be carrying the virus for a few days longer than the younger person. This comes from the cruise ships and other data. And that's probably the most that you can say. So in other words, their immune... And the other thing about being asymptomatic, by the way, is to do with the dose of the virus. It happens with other infections, and it looks as though it happens with the COVID-19 virus, is that if you get a really strong whack of the dose of the virus, so you're in the healthcare setting, somebody's really sick and they sneeze or cough in your face, you're a nurse or a doctor, and you pick it up. And that's what happened in China very early on. You had a lot of young doctors and nurses dying. Then you get more severe disease with the initial dose. But if it's a mild dose, then your immune system's strong enough to actually get rid of that quickly. So that seems to be the evidence that you don't carry it longer because your immune system isn't firing up. But the person writing that question in is absolutely right, that it almost certainly is asymptomatic because your immune system, a cough, a cold, runny nose, feeling unwell with a bit of a fever, that's your immune system trying to get rid of the virus. But with asymptomatic people, it seems to do that without those symptoms.
The American Red Cross is soon going to start testing, if they haven't already, I think they announced it in the last couple of days, testing blood donations for COVID-19 antibodies. Is the same thing going to happen in Australia?
Well, I don't think the evidence is in yet that it's valuable. So, for example, to check the blood system, the blood supply for HIV, you would check for antibodies.
Yes.
And antibodies is a strong indication that the virus is there.
Or has been there?
Well, no, probably still there, because unless
the fight is active.
That's right. It's come from somebody who has got some virus in their body. If you're on highly active triple therapy, whatever it's called, highly active retroviral therapy for HIV, then it can drive the virus down to very, very low levels. But antibody for HIV means don't give the blood because there could be HIV there. True for some forms of hepatitis as well. With COVID-19, if you've got the antibody, it doesn't necessarily mean the virus is in the blood. And so that could be somebody who was infected 3 weeks ago and there's no virus. So if they're testing for antibodies, I'm not sure, it strikes me as a waste of time and money because it doesn't help you. Because the virus could be gone. So it's like saying I had the flu in February and I test the blood, it'll pick up antibodies to influenza, but there's no influenza in my body. You're going to deny my blood to somebody who needs it? Well, no. And COVID-19 is the same. And there hasn't been a case of transmission. So I'm not sure why they're doing that. And I'm not sure what the policy is going to be here in Australia, but I think we've got to be careful what we spend our money on for not much benefit.
How close are we to getting a vaccine?
The answer is nobody can tell you that. There's a lot out there. There are a lot of vaccines the numbers vary. The success rate of vaccine development is between 5 and 10%. And there's maybe over 100 at the moment. The numbers vary, some drop out. So let's say there's 100, you'd expect 5 to succeed. But when are they going to succeed? When are they going to be able to prove it? In a lot of countries, they're coming off the top of the epidemic. Are there enough people in the community who are going to catch it naturally to be able to test the vaccine? Thousands of people have volunteered to be deliberately infected with COVID-19. That's fine. They do that with malaria, but with malaria, to test malaria vaccines, but there are drugs against malaria. There are no drugs against COVID-19 that will eliminate the virus. Although the new antibodies, where they've taken antibodies from people who've been infected and then infused, do seem to be quite effective. That may change the game with vaccine development, where it'd be safer to be infected and test accordingly. So it's going to take a while.
Parallel to all this is the investigation of appropriate treatment. So you might not get rid of the virus altogether, but will help you sustain and contain your symptoms, I guess. One of those drugs is dexamethasone, that's said to help treat patients on ventilators. What can you tell us about that and the efficacy of dexamethasone?
So dexamethasone was announced by press release 3 or 4 days ago that dexamethasone, in a large trial in Britain of 2,000 people who were either so sick they needed oxygen or they were on a ventilator, randomized, so people got it, versus 4,000 people who didn't get dexamethasone. And what they showed in that study, announced by press release, is that it reduced the chances of dying in both groups. A much higher reduction in the people who were on a ventilator than people who were on oxygen, but it did reduce mortality in both groups. Nobody has a chance yet, no independent expert has a chance to look across the data to see whether or not that's true. It's likely to be true because it comes from a very prestigious research group who've got a lot to lose and have got a big reputation. What's against it is that dexamethasone is not a new drug in intensive care, and it has been studied in the past, in years gone by, in influenza, serious viral pneumonia, not COVID-19, but before COVID-19 came along, serious viral pneumonia and serious influenza that's life-threatening. And dexamethasone has not saved lives, not reduced death rates in that group of people. So some people were surprised to find that dexamethasone might help in COVID-19 because that's not been their experience up to now. But COVID-19 is a different virus, affects the immune system in different ways, and it could be entirely different because it affects the blood vessels and so on. So it could be operating in a different way. But it's good news, potentially. Changing practice now has very low risk. Giving a short, sharp course of dexamethasone is very low risk in an uncontrolled environment. It's not something your GP would write a script for, but if you're sick, needing oxygen, or you're on a ventilator, it's a safe, pretty safe thing to do. And if it turns out not to be true, nobody will have died as a result of trying it out, and you won't have broken the bank because it's a very cheap drug. And the other drug, which is a more expensive drug called remdesivir, was not shown to reduce death rates, but did shorten the course in hospitals. And it may be using those drugs together, might be quite dramatic, yet to be seen. But nothing for your GP to prescribe saying, oh, you've got COVID-19, like an antibiotic script, nothing there yet.
All right, a final question for you that we get time and time again over the past few weeks. When will the pandemic be over? Is there a declaration made by a particular body somewhere in the world? This is not just a question about public health, it's also an economic question and a legal question when you're talking about things like insurance policies.
Of course. It's over when you've got elimination of spread or very close to it in most countries in the world. So it's a pandemic when you've got a virus spreading in a relatively uncontrolled way in almost every country in the world or every continent in the world. And it'll be over when the spread is largely eliminated in almost every country in the world. But we won't have eradicated it. It will almost certainly at that point become a seasonal virus, which can come back. So it depends on how much immunity there is in the community and how long that immunity lasts. So let's say the immunity lasts a year. That's what people are saying it might last. Then you could have an outbreak every year. If it lasts 3 or 4 years, it could come back every 3 or 4 years. But it will never get rid of it completely now. It's gone right through the community. And when a vaccine comes along, we'll keep it under control. But it's quite likely that vaccines won't be 100% effective. You might need to have one every year, like the flu. But it's and it might become a milder disease, but there's no guarantee of that.
Dr. Norman Swan, terrific to have you on the program as always. Thanks so much for coming in.
It's a pleasure, Jez.
And thank you very much for joining us on this live stream of the virus. We'll be back again next week with more of your questions, so stay in touch with us. We've had something like 70,000 questions since March sent in to us here at the ABC, so keep them coming in. We'll endeavour to get to as many of them as possible in the next few weeks. Thanks for your company. Goodbye.